Hi, this is Brian Kim. I want to share with you this case in which I'm going to load and inject the Bausch & Lomb LI61AO Sofport lens. Now this is a three-piece silicone aspheric lens, and so this lens is very effective at dealing with negative dysphotopsia. You're going to see how I'm able to execute a reverse optic capture configuration of the lens in order to mitigate negative dysphotopsia. This patient came to see me from out of state. She actually saw my YouTube channel and saw my explanations and cases of how I deal with the situation. And so she came to see me, and so we decided to place this LI61AO lens into the capsular bag and then reverse optic capture the optic. And so this is a case. You can see this patient has a nice sized pupil, and the cataract is, fairly standard, about a 2+ dense cataract. But this is a key. Making that corneal mark is very important so that I can achieve that reverse optic capture configuration. So again, I use that corneal marker, and then I make my incisions. And then instead of using the corneal marker as a guide for my rhexis, as far as the diameter and size of that corneal mark, I'm going to intentionally make the rhexis a little bit smaller than the mark. So I make my incisions, and then I inject intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, using the cannula to control the eye, and then I enter. These are the Moria microrhexis forceps. I'm going to puncture the center. These have sharp tips. Puncture the center, pull down towards me. And then I'm going to be very careful not to make a rhexis too big. If you make a rhexis too big, you can't do reverse optic capture. And so in this case, I'm going to make a rhexis smaller than I normally do. And remember, you want to make it small, but not too small. And of course, definitely not too big, because if you make it too big, you cannot buttonhole the optic. And that's essentially what reverse optic capturing is buttonholing the optic within the rhexis with the haptics in the bag, but the optic in front of the bag. So you can see I'm using the cannula to control the eye. And then again, I'm looking at the corneal mark that I made and intentionally making it about 1 millimeter or 2 smaller than my normal rhexis. Go ahead and finish off the rhexis, burp some viscoelastic and the capsule remnants out. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, decompressing the bag, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, pointing the tip down, the Phacoemulsification vertically sub-incisionally, fracturing the lens in half with opposing forces, and that is double chop. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it century toward the Phacoemulsification, and fracturing the lens against the Phacoemulsification. The Phacoemulsification is acting like a chopping block, and that is a cross-chop maneuver. Lifting that first quadrant up with some vacuum, fracturing the lens with opposing forces, and then emulsifying the lens pieces. Separating the second quadrant from the rest of the lens, hooking the peripheral lens, pulling it century toward the Phacoemulsification, fracturing the lens again in half with another cross-chop maneuver. Doing it again, I didn't get the chopper quite around the lens, chopped it again. Lifting the lens piece up. This patient is a high myope, so there's a little bit of zonular laxity in this case. crushing the lens with opposing forces, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, positioning the phaco-tip deep, crushing the lens against the phaco-tip with the chopper. Again, the phaco-tip's acting like a chopping block. Placing the chopper around the third quadrant, performing the same cross-chop maneuver, crushing the lens in half, and then using successive crushing maneuvers, crushing the lens with opposing forces, and then utilizing sparing amounts of ultrasonic energy and vacuum to emulsify the lens pieces. And this is the last quadrant, placing the chopper around the lens, hooking the peripheral lens, crushing the lens in half, using some vacuum to grab that piece, crushing the lens with opposing forces, and then pulsing it with ultrasonic energy and vacuum to emulsify the lens pieces. So all the endonucleus has been removed, removing the epinucleus now, keeping that chopper deep to protect the posterior capsule, just pulsing with the vacuum. Taking the chopper out, push BSS in, take the phaco-tip out, and I go in with the INA handpiece. There's a piece that's on the tip there. I'm going to mash the piece on the tip. Now it's gone. Starting sub-incisionally, removing the cortex from anterior to posterior, going around peeling from anterior to posterior circumferentially. By doing it this way, you get the cleanest removal of the cortex. Switching to polish mode, polishing underneath the rhexis edge. You can see the lens epithelial cells coming off, and you can also see that smallish size rhexis, well centered, but again, a little bit smaller than I normally do for my standard technique. Pulsing BSS into the subincisional capsule fornix, which was clean. Pushing cohesive viscoelastic to fill the bag, turning the irrigation off first. Polishing under the rhexis edge to polish the capsule of lens epithelial cells, first on the left side and then the right side. I'm going to go ahead and widen the incision because this is a 3-piece lens. You do have to widen the incision just a little bit. I use a 2.6, so I'm going to widen it just a touch. And then our attention is drawn to the lens. So again, we're going to load the lens. I'm going to show you how I do this. So this is the lens itself, the injector, and it has this weird kind of contraption that you're supposed to push that's attached to the side. I'm going to push some cohesive viscoelastic underneath that little platform there and then also along the barrel. And this is the lens. The lens has clips on either side. And right here where the red circle is, that is one of the clips. That's on that side, and there's another clip on the other side. And that's going to clip onto that platform for the injector. And then you're going to lock it into place. You're going to see how it's performed, and the lens will be within the injector. So I go ahead and push the clip down. You can see the lens, the lettering there. There's actually a stopper right there, and you have to lift that stopper in order to allow that slider to come down. And when you slide it into place, it actually causes part of the slider to cover over the lens so that the lens stays within the injector. So again, I'm using my finger to lift the stopper and then slide down, and then that causes that cover to go over the lens, take that cover off where the numbers were, and now the lens is in place. And then I'm going to further slide that. When you slide it all the way down, it clicks into place and you can't go any further. And now the lens is in place. And then this is a push style advancement. It's not a twisty style, it's a push. So you want to push, and as you push, you can see the lens is advancing. You want to make sure that the entire lens, the leading haptic, the optic, and the trailing haptic are all moving together. You don't see any pieces that are coming off. So again, make sure you don't have any amputated pieces. And then there's a stick that's sticking out from the tip. You slide that out. And then you see that bubble at the tip of the injector. I'm going to just push some viscoelastic in there to evacuate the bubble. So we're ready to go now, okay? And so now I'm going to place my cohesive viscoelastic cannula through the paracentesis incision. I have my thumb on the plunger. The lens is inside the eye. I'm advancing the leading haptic into the bag. Because this is a silicone lens, it opens up rather abruptly. You're supposed to be able to deliver the trailing haptic at the same time with the injector, but since this is not my routine lens, I would prefer not to inject the trailing haptic at the same time. I just leave it outside the eye, and then I use a Maltzman to dial the trailing haptic in. Go ahead and irrigate the surface of the eye. Activate irrigation, get underneath the lens, removing the viscoelastic from within the bag. And then using the INA tip with infusion on, I'm carefully lifting the optic in order to cause the reverse optic capture. So again, very easy. You're just lifting the tip of the INA handpiece that causes the entire optic to come up anterior to the rexus edge. And because my rexus is small, as I slide the INA handpiece out, it maintains that reverse optic capture configuration. And then now I'm able to easily remove all the viscoelastic from the anterior chamber. And even though I have high infusion pressure, because I have a nice tight reverse optic capture, because I made my rexus small, it's able to maintain and achieve that reverse optic capture configuration. I remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you're going to see at the very end here, I have a perfectly well-centered lens. The haptics are within the bag, and the optic is anterior to the rexus edge, and a buttonhole configuration, which is called reverse optic capture configuration, which means that the optic is in front of the capsular bag plane, meaning that it's closer to the iris plane, and this is supposed to mitigate negative dysphotopsia. By keeping the lens closer to iris plane, the chance of there being a shadow that's being cast by the edge of the lens is less noticeable because there's less space between the optic and the pupillary edge, and therefore reducing that dark shadow on the temporal side of the patient's peripheral vision. And you can see here now the cat eye configuration or lemon-shaped configuration of the reverse optic capture. You can see the rexus is not round. It's in this cat eye configuration, and that is because the haptics are within the bag and the optic is anterior to the bag, maintaining that unique rexus configuration. So luckily this patient came after surgery, even post-op day 1. She was seeing 20/20, and she said that she did not see that strange shadow and flickering of lights on the temporal side of her vision, because the other eye, which had surgery elsewhere, has that problem, and it was really bothering her. She did not want to have that happen with this eye, and so we did the second eye with reverse optic capture configuration. She was very happy with the results, and we are going to exchange the first eye lens and then also perform a reverse optic capture configuration with another LI61AO soft port Bausch & Lomb lens. So hope this was helpful to you, and thank you for your attention.